Hello, everyone. Today is January 21st, 2021, and welcome to the International Interprofessional Mentorship Program. Margaret Maynard and Susan Morehouse are presenting on brachial plexus injuries. Please put yourselves on mute and hold all questions until the end. If you would like to receive a certificate of attendance, please enter your full name and email into the chat box now. Thank you all for coming, and let's get started. Thank you, Margaret and Sue.
Thank you so much. My name is Margaret Maynard. I video off just because I have unstable internet, but I just wanted to say thank you for having us, Kate. It's really great to be able to provide some education on the brachial plexus birth injuries. So just for everyone's awareness, I'm actually an occupational therapist. I'm board certified in pediatrics and a certified hand therapist. So I work at Boston Children's with my colleague Susan Morehouse, who is a pediatric physical therapist who's been in the clinic actually for many years. So together we have worked with this population for 18 to 25 years. Though individually we have worked in different settings at different times. So we currently work on an interprofessional upper extremity team, which is inclusive of orthopedic surgeons, nurse practitioners, researchers, and physician assistants. Next. Next slide, thanks. So the goals for our presentation today are really to kind of provide you with a brief overview of the anatomy of the brachial plexus, evaluation of brachial plexus birth injuries, critical timelines and healing, as well as treatment interventions in different age ranges. So we based our presentation on the World Health Organization ICF model, as this is the model that we use in our daily practice. We divided our presentation up for ease of presenting, so we want to welcome any questions you may have at the end, as Kate had mentioned. Thank you for muting yourself during the presentation, but when you do want to ask questions, please feel free to come off mute at the end. So with that, I will turn it over to Susan.
Great, thank you so much. Again, thank you so much everyone for having us here today. It's really exciting for Margaret and I to share. We're pretty passionate about this patient population for sure, and have a lot of content to share. We did try and divide the information up a little bit half and half, where the first half of this is going through and reviewing a brachial plexus injury, and the second half is more directed towards conservative treatment options. I'm just going to turn my video off as well. I hope you guys don't mind. Seeing myself sometimes distracts my presentation skills. So I'm just going to take a second just turn myself off video. And then just Margaret and I, we do not have any disclosures for today's lecture. So we just wanted to start off with setting up some of the foundation as we discuss brachial plexus injury with a brief review of the peripheral nerve structure. And just the goal of the slide is just to recognize the different components and layers to the structure of the peripheral nerve as it relates to the different classifications of nerve injury, and how an injury to the nerve can subsequently affect the musculoskeletal system, specifically in childhood. So I just want to take a quick second here and just briefly review a nerve. I'm not going to go through this in great detail, but just to kind of get us all on the same playing ground real quick. So we have this first, this epineurium. This is the first layer that surrounds the entire nerve. And the epineurium also has an internal layer, which is in between each of these fascicles. So this epineurium is also internal in this blue area. And then these fascicles, which are these bundles of nerve fibers, those are surrounded by the layer called the peroneum. And then what we have is the endoneurium, which then covers over that nerve fiber, which, as we know, we have our axon. So as we all know, we can recall we have that axon that comes down, and when an action potential or an impulse is conducted along that axon, there's this chemical reaction that occurs here through this neuromuscular junction. And then ultimately this does result in that muscle contraction. So just to keep in mind, when there's an injury to that nerve, we'll lose that function to that muscle. And that muscle no longer has that ability to contract as a result of a denervation process. So it undergoes atrophy and has changes to its overall quality and properties. So just to kind of reorient ourselves to just the basic aspect of structure towards that nerve. So these are the classifications of nerve injury. Seaton did classify peripheral nerve injuries into these 3 different subtypes. So you have the classification of neuropraxia, axotomesis, and neurotomesis. The neuropraxic injuries, these are the mildest type of nerve injury. This is where paralysis to the muscle is a temporary paralysis because the connective tissue structures of the nerve and the axon are essentially still intact. These type of injuries do heal spontaneously and a full recovery is expected. So this is why these are considered to be more of that mildest type of injury, because we expect a full recovery. And moving into axonotomesis type of injuries, this is an injury that surrounds the occurs to the axon, but the surrounding structural layers are still intact. This still allows a path for regeneration of that axon. And as we can all recall, regeneration is a slow process. So this occurs at approximately 1 millimeter per day. So just keeping that in mind, that if we have a nerve injury, where it occurs in the brachial plexus and the distance that nerve has to regenerate to reinnervate that muscle. And our last classification, neurotomesis, this is where all the essential structures of both the neural and the supporting tissues have been disrupted. And these injuries do not generally regenerate, and they require surgical intervention in order to restore function. And then just in this column here, we have Sunderland, who further classified nerve injuries into these different subtypes, just to distinguish the different structures of the nerve that are involved. So when we're talking about the brachial plexus, one type of injury that we need to also acknowledge is that an avulsion injury can occur. So an avulsion injury, this is where the nerve root has physically been detached from the spinal cord. And an avulsion injury, this is considered to be a preganglionic injury. It carries a worse diagnosis and prognosis, as the nerve cannot, there's no way of surgically reattaching these nerve rootlets to the spinal cord. So essentially that plug has been disconnected from the wall, so to speak, without any way to plug it back in. And then we have our examples down here. These are our post-ganglionic injuries, which were previously discussed on the last slide. So where we have our ruptures and our neuropraxic type of injuries. So just to get into the diagnosis that we're actually talking about today, so brachial plexus birth injury, it's defined by the paralysis of the upper extremity due to a traction injury or a pull injury to the brachial plexus that occurs during the birth process. And as we can all recall from our anatomy, the brachial plexus is actually quite a complex network of nerves, and it arises from nerve roots C5 through T1. To provide essentially that innervation to our upper extremity. So I know this image is quite busy, but it does kind of depict how complicated this highway network of nerves is with regards to this specific injury. So how common is this injury in the population? It has been varied in different reports. One of the most recent ranges that I came across in literature was about occurring in 1.5 to 5.1 of every 1,000 births. And this is in developed countries. So I don't have any information in underdeveloped countries on how common this injury is. But the variance in this range has been postulated to be due to differences in prenatal care and regional differences in average birth weights of babies and differences in maternal pelvic size. And it's important to note, in the United States, we did have a decrease reported incidence recently, and they're also theorizing that's potentially due to increased rates of cesarean sections being performed, labors being induced earlier, and multiple births occurring at once. So just to move into some of those risk factors, these are some of the most common known risk factors which may be associated with having a baby with brachial plexus birth injury. Macrosomia, this is defined as a baby whose birth weight is greater than 4.5 kilograms or 9.9 pounds. This does carry a 20-time higher risk of potentially having a baby born with a brachial plexus injury. Your prolonged second stage labor, if the mother's been pushing for a prolonged period of time and there's a failure of delivery of the shoulders, this is another risk factor. Use of instruments during delivery, forceps and vacuum, breech delivery where the baby's entering the birth canal feet first. Breech deliveries do have a 9-time greater risk of a brachial plexus injury when comparing it to a vaginal delivery of an average birth weight. So just to note that as well. And a prior delivery resulting in a brachial plexus injury does also present as a strong risk factor for a potential birth injury. And then this last one here, shoulder dystocia. This is the greatest known risk factor, and we're just going to review this a little bit more in detail on the next slide. But before I move on, I just wanted to point out that out of infants born with brachial plexus birth injury, only 50% of those infants present with these risk factors. So that leaves another 50% that don't have any known risk factors. And that in itself can be a challenge in just noting that that brachial plexus birth injury is somewhat unpredictable. So just to highlight what shoulder dystocia is a little bit more, this is when the baby's shoulder is essentially stuck on the mom's pubic bone as seen here in this image. I don't know if you can see my cursor very well, but so essentially that shoulder is stuck on that pubic bone. And this may present during the delivery as a turtle sign where the head will come out and then go back into the birth canal and come back out and go back into the birth canal. And that sometimes is a signal to the delivering physician or obstetrician or midwife that there's a shoulder dystocia situation that's happening. So this is basically utilizing that analogy of a turtle poking its head out of its shell, poking it back in, poking its head out and poking it back in. And in cases of shoulder dystocia, this is actually considered to be quite an emergent situation. They're trying to deliver that baby that's stuck. They're trying to do it in a very time-efficient manner to reduce any other injury to that baby and prevent any potential anoxic type injury. So usually a code is called where a huge team comes in running into the room to try and assist. There's obstetric maneuvers that they'll try and perform to try and release that shoulder. But ultimately, what ends up happening is force may be really needed to try and deliver that baby, to get that baby out as soon as possible. And that quick or increased force creates that traction to the brachial plexus, resulting in that subsequent injury. So Neuracus provided us with a classification of different groups of injuries that occur with brachial plexus birth injury. So in the first classification, Neuracus group 1, this basically is a description of an injury to the upper trunk of the brachial plexus, C5, C6. This usually manifests with an absence of these movements where there's weakness or paralysis of the deltoid, the supraspinatus, your external rotation from your infraspinatus musculature, your biceps, in addition form supination. So when we're thinking about this group, they have those muscle groups that aren't innervated, but then we have innervation to and function of shoulder internal rotation, adduction, elbow extension, wrist and finger flexion extension. So there's an imbalance of which muscles are firing at a time in these babies. And we'll get into a little bit of the importance of that during some upcoming slides. So in neurocus group number 2, there's absence and weakness of the musculature that and movements that we described on the previous slide. But then we also have the additional dysfunction or paralysis of your triceps musculature, your wrist extension, and your finger extension function. And your neurocus groups 3 and 4 are grouped together on this slide because they're similar with just one difference. In neurocus group 3, this is a global injury of the plexus. So you're C5 through T1. The movement of the arm is it's flaccid, it's flail, it's lacking movement. In these type of injuries, it's often a combination of both those preganglionic nerve root type avulsion injuries, so your more severe injuries, in addition to your postganglionic rupture type injuries. And neurocus group 4, the distinguishing factor with that is that this presents with a Horner syndrome. So if you can see my cursor here, this is a kid that has a pretty obvious Horner syndrome, which demonstrates ptosis or drooping of the eyelid. You can't see this in this picture, but a Horner syndrome may also be demonstrated by a change in the pupil. The eye may appear a little bit more recessed in the eye socket. And what this Horner syndrome indicates to us, it indicates that there's been an avulsion injury to the T1 sympathetic nerve root from the spinal cord. So when we have these avulsions, we know these are preganglionic injuries, and they do carry more of a poor prognosis. And then this last aspect here, possible phrenic nerve palsy, it's just worth mentioning because the phrenic nerve arises from C4, and it's not very common, but in approximately 5% of upper brachial plexus injuries, an injury to this nerve can occur, and it does present with some issues with the diaphragm. So the prognosis with this diagnosis, it really is highly dependent upon the extent and the type of the injury. It's important to note that most children do recover spontaneously. Literature currently is supporting about 66 to 82% of babies will go on to recovery. If there's early return of biceps function by 6 weeks of age, we know that baby's gonna go on to a full recovery without needing any assistance or help. They're gonna recover spontaneously. However, the remaining percentage of those infants may have lack of recovery and it may be delayed, which then results in persistent neurologic deficits and may require surgical intervention. So that's where these timelines really come into play with our exam, the physician's exam, and making sure that we're not missing the physicians able to provide surgical interventions when they can. And then just important to note on this table here that your global injuries with your Horner syndrome, so your group 3 and 4, that neurocus group, does carry really a poor to no chance of natural nerve recovery based off of the severity of the injury that happens. So again, these are the babies that will really require a lot of care and a lot of potentially medical interventions to assist and improve upon their function. And differential diagnoses are just important to note. You know, when brachial plexus injury is suspected, typically, you know, at the time of birth, you know, if there's been a difficult delivery, if there's been presence of those risk factors, and usually abnormal movement of the arm is present, and reflexes such as the Moro is typically absent after birth. So that would lead the physician or the obstetrician to suspect that, you know, brachial plexus injuries occurred. But it's just good to know that and be aware of that these are some other diagnoses that may manifest as a decreased movement of the extremity. And I just want to point out that this last one here, fractures. So if we can just, you know, think back to trying to deliver that baby as quick as possible, deliveries can actually be quite traumatic where fractures can occur. So oftentimes there can be a fracture of the clavicle or the humerus in the setting of a really traumatic delivery. And this can manifest as decreased spontaneous and movement of the upper extremity or the limb. So in cases where a fracture is suspected, typically an X-ray is performed. And it's important to note that a fracture may occur with an injury to the brachial plexus, or a fracture can occur alone, resulting in decreased movement of the arm. And sometimes you really can't distinguish between the two until after that bony healing has occurred. So if after bony healing's occurred, there's full active movement of the arm, likely there was probably more just a lone fracture that occurred. There may have been a neuropraxic injury as well, but these kids, if they do have return of active movement after healing of the fracture, usually it's in a lone injury. And this is just a 2 images. So on our left-hand side, it's kind of hard to see, but there is a fracture line to this clavicle in this infant. This is an infant with a concurrent brachial plexus injury at the same time. And it's pretty obvious to see this humeral fracture on the right-hand side. You really can't miss that there was a fracture that was there. And again, this is another baby who, after healing of that fracture, did end up having a concurrent brachial plexus injury at the same time. So they had deficits of nerve function that were obvious after bony healing. And just important to note that diagnostic imaging of the brachial plexus and EMG nerve conduction studies are not commonly performed in the infant. MRIs typically require sedation. EMG nerve conduction studies are not necessarily the most comfortable tests to perform specifically in an infant. So kind of our gold standard at current is performing serial clinical examinations when we're really trying to determine how well a child is doing with respect to their nerve recovery. So just important to note, some places do perform these tests, but they're not necessarily common, and they're not utilized alone to determine the nerve surgery need. And EMG nerve conduction studies have not, for reasons that we really don't quite understand, have not been really found to be highly reliable in infants as well. So we're just going to go through our presentation utilizing the ICF framework. This is definitely something that we consider in our clinic, utilizing our interprofessional and collaborative practice to really optimize patient-centered care. So as Margaret and I go throughout this lecture, we're just going to bring in elements of this ICF model as we talk about different stages. And our first stage we're going to talk about is this infant stage, birth to 12 months of age. And in consideration of that ICF model, the emphasis of care in infants with brachial plexus injury focuses primarily on impairments of body structure and function in this age group. So these are just some examples of some of those structures and functions that might be impacted in an event of a brachial plexus birth injury. In infancy, our team performs serial monthly exams to promote recovery to ensure that critical surgical windows for nerve surgery and maintaining health of the musculoskeletal system are identified. And with brachial plexus being the primary body structure function affected, again, these are just some of the examples, but we're going to focus a little bit more on that musculoskeletal structure as we move along the next few slides. And we're looking at body structure and function in the infant, both through our clinical observations and through manual examination. And an evaluation of both active movement and passive movement of the upper extremity really is key in this age group, specifically as we're looking for patterns of nerve recovery. So first, just to start with our clinical observation, this begins with us observing that spontaneous movement of the affected upper extremity. This does provide us with improved understanding of where that current upper extremity function lies with respect to muscle function. It's important to assess as well, looking at our utilizing our clinical observational eyes, if there's any atypical movement patterns which may be suggestive or independent of any other conditions, which might lead you to think that the child might need further medical evaluation. So it's important for us just to keep in mind those differential diagnoses as well. This is actually an image of a baby with a brachial plexus birth injury on the right side. So if we kind of look at this left side, we can see this extremity is in a nice externally rotated position. We have beautiful elbow flexion that's firing. We don't quite see that on this side. And I can tell you this baby's clinical exam finding at this time when this image was taken did have palpable biceps, but did not necessarily have any active movement at the elbow joint. So when we're seeing this image on the right-hand side, what we note is the elbow is flexed, hand towards mouth. We note that the hand is in a position of forearm pronation versus a supinated position where we'd expect a baby hand to mouth to have rotation through the forearm. And I can tell you that because this baby at the time the image was taken did not have good active biceps function, her ability to get her hand to her mouth was all gravity assisted. So basically what she ended up doing was flinging her arm up, utilizing what muscle function she had through her pectoralis muscle at the time to generate momentum of movement. And then her arm, gravity assisted, went to her mouth. So just focusing a little bit on upper extremity posture, this can actually tell us quite a bit too, just in addition to observation of our spontaneous movement. This also gives us that idea of what current muscle is functioning like. And it also kind of leads us into what other things we need to look at as far as our manual exam. And then as you can see in these two images, it does a really nice job because these are two different babies. So it really does demonstrate the difference in variability of posturing that can be seen, keeping in mind that there's varying degrees and types of injuries, which we reviewed previously. And then just a quick little plug here, we want to also note when we're looking at posturing, if there's any asymmetries in cervical positioning, and if we identify that there's any torticollis or plagiocephaly occurring, that we make sure that we're starting to include that in our therapy treatment plan of care. And then our skin inspection exam, this is also included as part of our clinical observation assessment. And just to note that there's a small percentage of infants and children with brachial plexus injuries that may demonstrate self-mutilating behaviors or biting of their affected hands. The reported incidence in the literature, it's small, it's 4%, but it does appear to be a little bit higher in those babies that have had reconstruction or nerve surgeries. And why they do this is really not well understood, but there are some theories that maybe it's possibly due to the abnormal sensations or pain that's experienced during the process of nerve regeneration. So we can see in these images, this is actually a 10-month-old baby who began to have these self-mutilating behaviors. They had a severe global C5 through T1 injury that did require reconstruction. And at 5 months post that reconstruction is when he began these self-mutilating behaviors where there's biting at the tips of the fingers and a little bit into the nail. And just this is important just to keep in mind and just be aware of. Again, it's not very common, but we do want to make sure that we're looking out for any excessive mouthing or biting in the hand to minimize any risk of infection, or sometimes a protective splint is required to prevent any further injury. So in brachial plexus birth injury, there's not only an injury to the nerve, but it also results in impairments that occur to that musculoskeletal system. So due to that nerve injury, there may be that complete absence of muscle function or partial paralysis with weakness due to that impaired nerve innervation. And this results in muscle imbalances. So what we also know in children and infants is that muscle imbalances across their joints does result in bone and joint deformities due to those abnormal forces on the joint that's currently undergoing development. And this is most commonly observed at the shoulder joint in brachial plexus injury. It's really well known and well published that when there's an imbalance of those shoulder internal rotators, overpowering weak or lack thereof of shoulder external rotators, this can occur and result in bony and joint deformity. And we're going to review that on the next few slides just to give you guys a sense of what that looks like. But just keep this in mind when you're seeing those kids with those C5, C6 injuries, because those are the babies that have that internal rotation function, but don't necessarily have that external rotation function resulting in that muscle imbalance across that glenohumeral joint. And then certainly we have to keep an eye out for joint contractures, impairments of muscle length, and impairments of bone growth. So just to expand upon that bone and joint deformity, specifically with the shoulder, it's important to note that studies have shown that shoulder dislocation can present in early infancy. And this can be confirmed on ultrasound and typically presents with a reduced passive shoulder external rotation in a position of adduction when you're performing your manual passive range of motion exam. So I've just included this study here performed by Bauer and et al. In their cohort, they had 29% of their infants that they assessed with ultrasound screening of their shoulder demonstrated posterior shoulder dislocation, where basically there's an abnormal development, a developmental dislocation of the glenoid and the humeral head alignment. And what the authors suggest from that study is that ultrasounds performed in infants when there's a demonstration of a passive loss of shoulder external rotation in a position of adduction less than or equal to 60 degrees. And really the importance of this is really to further assess that glenohumeral joint development and to intervene when able to provide any further progression and joint change. So this slide is really meant just for your reference, but again, glenohumeral joint deformity in this patient population is really well known and recognized. And I just want the takeaway from this slide is just to recognize that there is a pattern of deformity with progression that can occur, certainly from grade 1 all the way up, where we have really a severe deformity and there's really a lack and dislocation of humeral head articulation with the glenoid. And this is usually measured through an MRI. And it's important because studies have shown that internal rotation contractures, this is important to us as therapists because this correlates with glenohumeral joint deformity. So those babies that have contractures into internal rotation have a higher chance of having changes at the glenohumeral joint. And what we know is that, excuse me, what we know is that deformity appears early in infancy as seen on the other slide, and it progresses over time. Just take a second to cough and just get a little water here. I've included here, this is an MRI that's performed on a child with brachial plexus injury. I just want to orient you to a few things on this MRI, just so we can understand where we're at. This side is our normal side. And so this right here is our scapula. This is our glenoid. And then this is our humeral head. So when we're looking at a normal shoulder, what we need to see and what we're looking for is we're looking for a nice round humeral head. And we're looking for that humeral head to be relatively centered over the top of that glenoid. So almost like a golf ball resting on a golf tee. When we look at the other side, which is our abnormal side, if we drew a line that bisected that scapula, we can see that that humeral head, which is no longer round in shape, so it has a misshapen appearance to it, sits behind that line. So this is essentially a shoulder that does have deformity and posterior dislocation. And the other nice thing to point out with this is if we look at this nice shoulder here, we can see a really nice rotator cuff muscles and a nice deltoid. And if we compare it with our other side, we can see that the quality of that muscle is different. So this is a part of that process when a muscle is denervated that the muscle goes through. We get fatty infiltrates and atrophy that can occur. So we're looking at the rotator cuff muscles, we can see how it's atrophied, and the deltoid is atrophied when we compare it to the uninvolved side. And this is just important for us as therapists to keep in mind that when we're doing strengthening interventions, to keep in mind that that muscle may not be a normal muscle. We may have a muscle that's got those property changes to it. So there might be limits to how strong we can make that muscle through our interventions. So just a side note there, just to keep in mind. So our passive range of motion is in muscle length assessment. It's a big part of our manual examination. It's critical to assess for any joint contracture or muscle length deficit. We teach this pretty much at each clinic visit to detect for any interval change, as we found that increased muscle imbalances can occur upon changes in that muscle reinnervation. So because internal rotation contracture is correlated with that glenohumeral joint deformity, passive external rotation range with shoulder in a position of adduction, as we have in this image here, is really assessed and essential to monitor at each visit. We want to make sure that there's no progressive loss in that range of motion, and knowing that that might correlate with deformity that's occurring. So we do note that external rotation range loss is being observed. Certainly that's a discussion with the medical team, and they may decide to utilize interventions such as Botox injections to the shoulder internal rotators, and they may place the arm into a spica cast where the shoulder is placed into an externally rotated position, basically in an effort to prevent any further progression and to buy us some time, so to speak, if there's continued nerve regeneration that's going to occur. And in some infants, they may require early tendon transfers about the shoulder. It's not as common in this age group, but tendon transfers tend to be more common in the ages of 2 to 5. But if it's needed, sometimes they'll take the latissimus dorsi, the teres major tendons, and they'll transfer them so that they then become external rotators to essentially rebalance those muscle forces across that glenohumeral joint when there's a lack of that external rotation function. So this is actually a child who, if we can just look at this lower right-hand image here, this child has a significant internal rotation contracture. And this is actually as far as I can manually range him. So he's got a pretty significant passive external rotation loss. We're looking for trying to aim for getting external rotation range as symmetric with the uninvolved side as possible. So this is a baby who has really significant marked glenohumeral joint deformity, which we can see clinically we're not able to achieve that passive external rotation. I can't even bring him to a neutral rotation. And then this image over here on the far left, it's a little hard to see. Where this arrow is pointing is an area where on clinical exam, if we put our thumb into that posterior soft spot of that shoulder, what we can feel is we can actually feel that humeral head posteriorly on exam. So when we rotate the shoulder, internal and external rotation, we shouldn't be feeling that humeral head popping out on a normal shoulder. But in these babies, sometimes you'll see that and you can palpate it. And I know it's a little hard to see, but there really is a little bit of a prominence that's a little bit more evident when you're seeing them in person. There's a prominence here that you can see with your eye as well. So again, you know, our passive range really is an important aspect of our manual examination. It's important for us and provides us with essential information in this age range so that we can provide that feedback to physicians and parents if we do identify that there's a concern regarding those changes. And our manual and observational exam also consists of looking at active movement function. So specific to this brachial plexus population, we utilize the Hospital Children Active Movement Scale at each clinic visit. And we're looking and utilizing this to assess if there's any changes in muscle function with any potential nerve reinnervation that's happening. And this specific tool was designed by the Hospital for Sick Kids. And it does have published instructions. We did not include, Margaret and I didn't include that as part of this talk, but online you can actively search for this, and it comes up with pretty detailed instructions on which positions you need to put the baby in to look at these motions on the left-hand side and these gravity eliminated and against gravity planes of motion. And this scale has been shown to be reliable in assessing movements with this diagnosis from the newborn to 12 months of age. And what it does is it quantifies the strength by observing that spontaneous active movement against gravity and in those gravity eliminated planes. So we'll give kids scores based off of the movement that we observe, and that allows us for tracking of recovery and how well that muscle is doing. And this slide, this is more for information, FYI, but the Toronto score, it's also another tool that's utilized to assess for muscle function. It was designed to quantify and predict recovery in infants, and sometimes is utilized as a tool or a predictor for identifying potential need of nerve surgery. And just more for you guys to be aware of, if you see it in any physician notes, if it's documented in any research or studies that you're reading about. And really the big difference between this scale, between the Hospital for Sick Kids scale, is this scale is all against gravity. So these muscle groups above are scored and given a clinical grade against gravity, whereas the Hospital for Sick Kids active movement scale considers those anti-gravity or emerging movements. And just clicking along here, these are just some examples. We often use manual stimulation, tactile stimulation, stroking along the skin, tapping along a muscle group, palpating the muscle belly is key when we're looking to assess that muscle function in a baby. And I'm not going to go through each of these ones individually, but it does kind of give you a little bit of an idea of where you would kind of look and palpate and try and stimulate to try and encourage a muscle response. And actually, I think this is probably our best kind of look here, but down when we're trying to stimulate thumb extensors, if I do a stroking move down here, you're going to see it actually elicited some extension movement at the thumb. And just moving on within our ICF, these are just some other things that might be impacted, with relation to activity. As part of that model. So hands to mouth, holding a bottle, self-soothing, object manipulation, reaching skills, certainly, mobility, transitional movements. This is not an all-inclusive list, but just things to think about as far as impairment of activity. And then, and the infant's impaired mobility might also impact their ability to participate in environmental and social interaction opportunities. So I'm just keeping that in mind as far as participation. And environmental factors, again, not an all-inclusive list. However, these are some of the things that might play a role into that patient or child's care. And I just want to highlight maternal stress up at the top here. As we described that this delivery and injury can be described as a traumatic in nature, and certainly the parent and family were not expecting their child to be born with this type of an injury. So maternal and parental stress and anxiety can be present, and this may affect their ability to process information that we're trying to provide to them with respect to that diagnosis and treatment interventions. So it's just important for us to just keep in mind and to reinforce that education at each visit. And then certainly personal factors, not an inclusive list, but considering extent of injury and if there's presence of other comorbidities. So just moving away from that exam aspect a bit and moving a little bit more into that treatment part. So we, definitely have more of an understanding of what the consequences are to the musculoskeletal system, so we can recognize our therapy treatment interventions are really going to be geared in the infant towards optimizing that muscle length, passive range of motion. And these are just a few examples of how we do that through passive stretching, soft tissue mobilization, and use of orthoses. And Margaret's going to be discussing in the upcoming slides a little bit more in detail regarding the orthoses. And we just have some images on keeping that shoulder nice and loose. Again, trying to just emphasize the importance of trying to maintain that glenohumeral joint health, trying to maintain that external rotation range of motion. Stabilization of the scapula is helpful as well if we are able to stabilize to try and isolate through that glenohumeral joint. Do want to recognize that we do expect the scapula to move with shoulder abduction and shoulder flexion. However, sometimes these babies will demonstrate increased tightness in between their scapula and humerus, which requires stabilization of their scapula when we're stretching them. And of course, we want to keep that elbow and forearm nice and loose. So again, just some examples depicting how we are encouraging patients, families to do that through a home exercise program. And keeping in mind a nice and loose wrist extension, wrist flexion, and finger extension. We really want to emphasize if the family is able to perform this many times throughout the day, specifically in those babies that have that muscle imbalance, where they may have tightness of their finger flexors, their thumb flexors, really trying to emphasize frequent performance throughout the day to really try and optimize that muscle length. And this is actually an orthoses that was developed, and Margaret and I, we've included this link here because it includes really nice detailed step-by-step instructions for you guys to refer to on how to fabricate this if you have that available to you. But what this essentially does in those babies, if we're identifying their shoulder rotation is heading into some trouble in terms of loss of motion, or if we're trying to nip any loss of motion in the bud, so to speak, we'll try and fabricate this type of orthosis to try and keep that extremity in more of an externally rotated position. And our facility, we do recommend use of this when it's indicated for nap time and nighttime wear only, as to allow active movement during the day. And I think this might be the part that Margaret kicks in. And if Margaret, is this where you kick in?
Yes, thank you, Susan. So we're just going to move into some therapy interventions. And again, we're going to do it by age ranges just to make it easier to group it together for everyone's understanding. As Susan mentioned, we're really in the infant age range looking to improve that child's awareness of their upper extremity while continuing to increase their muscle activation. Next slide. Okay, I apologize. We're working technical difficulties. So I'm sorry, I'm just a little bit delayed. So basically in the infant's age range, we're really focusing on positioning and facilitation of age appropriate skills. They should be key parts of your therapy to make sure that we're encouraging integration of the affected upper extremity so that way we can prevent learned disuse. So weight bearing, bilateral upper extremity play, those are all as equally as important as encouraging that single arm reaching and increase their ability to integrate that affected upper extremity. Next. So in therapy, we are considering the progression of muscle strengthening from gravity eliminated to anti-gravity positions. So as you can see here, I'm facilitating gravity eliminated shoulder flexion. And this position is great because in side lying, it also assists with helping children get their hands to midline. This little one actually used side lying extremely effectively to get both hands on toys before she would then roll to her back and try to engage in activities of like banging toys. In the picture on the bottom left, I've already facilitated gravity eliminated shoulder abduction. So while she's in that position, I then bring her elbow slightly into flexion because her triceps are too strong. They're overpowering her biceps. And then in this position, I'm actually encouraging external rotation as well as bicep flexion. I'm really trying to get her to begin to bring the shapes in her hands to midline for hand-to-mouth exploration, which is completely appropriate at this age. It's also important to facilitate this position because it really brings the objects into the child's visual line of sight, which they are not able to do on their own if they lack deltoid function. So children, as you can see in the middle, will be children. They're going to grab onto toys, they're going to explore, and honestly, no matter how awkward it is for them, we should support their exploration management of toys because it's extremely important for their own cognitive development. And this is where they also begin to learn strategies for motor planning. In the last picture, you can see I'm encouraging active participation in dressing, no matter how challenging it may be. It should always be encouraged. All too often, we hear from parents, it's just easier to get the child dressed. But this is actually a disservice to the child's learning of how to complete ADLs on their own. Next. Again, this child here had the misfortune of having bilateral upper extremity brachial plexus injuries. Her right side, as you can see, is more affected than her left, though she did have microsurgery on her left side, a few months earlier than these pictures were taken. Encouraging reaching to isolate deltoid muscle function for abduction and flexion, as well as cross-body reaching, is what I'm trying to encourage here. As you can see, I'm gently blocking her from rotating her body or using her opposite hand. Next. So getting back to the importance of weight bearing, it is essential we ensure children move through the normal sequences of transitional movement patterns. So most of you, I'm sure, are probably cringing at the picture of this little boy weight bearing on the back of his wrist. However, this mobility is extremely important for improving his strength through his shoulders, neck, back, hips, and abdominal muscles. When children are free to mobilize, they develop visual spatial skills, and the exploration of their environment really helps with the development of cognitive skills. So you can forward one more. There are weight-bearing splints that can be used when wrist extension is weak, though we also do not want to have a child in a splint full-time because it will make it hard for them to develop the strength and manipulation skills in the affected hand, and that can also hinder bilateral upper extremity coordination. Next slide. So these pictures are just showing you another handy option for weight bearing on a short stool while you're working on high kneeling, really trying to engage the hips and the trunk. Next slide. So one treatment intervention that we use is electrical stimulation to work on strengthening during functional activities. I do want to emphasize that the use of e-stim should not be completed unless you are properly trained. But we did want to include a few examples of how we use it during functional activities. So this is the same child from one of the previous slides who had the significant weakness through his wrist extensors. So on the left side, you can see Susan is pressing the button to activate the e-stim while trying to engage the wrist extensors while reaching for that plastic coin. And then when the child is working on placing the coin in the bank, she, on the right picture, releases her thumb from the button, which turns off the e-stim, which allows the child to release in a normal movement pattern. So e-stim is something that can be done around the shoulder. It can be done during reaching tasks. It can be done on the bicep when working on midline function. So there's definitely a use for e-stim, though we also want to make sure that we are not using it with patients who cannot necessarily let us know that it's painful. it's really helpful to have a palpable contraction when the e-stim is on. And again, if you're interested, it would be strongly encouraged that you would not use it unless you're trained. Next. So as children get stronger, we want to begin to challenge them. So here you can see Susan is working on improving this little one's ability to support their weight in quadruped while working to improve the sequencing of the crawling pattern. Sometimes this is actually a little bit easier when you're doing it up on an incline. But as you can see, the child is working on weight bearing on an open palm. However, Susan is not overcorrecting him through his hand every single time. So that way he can begin to work on self-correction. So he starts off weight bearing through his fist, and gradually, as you can see, after several repetitions, he actually does self-correct and get his hand open on an open palm. So the next slide. We did talk a little bit about possible nerve surgeries. There's definitely nerve surgery that occurs when there's failure of recovery. From an OT and PT perspective, following the nerve surgery, we reinitiate therapy when that swath bandage is removed, typically at 4 weeks, 3 to 4 weeks, depending on the physician's recommendation. And then we begin passive range of motion, and we facilitate active range of motion, and we keep, working on strengthening the muscles that we already know are well innervated. It's very important for us to educate parents and local providers that following nerve surgery, return of motor function is not immediately seen. There's a lot of evidence that early signs of motor reinnervation, it can sometimes take up to 3 months. But more typically, I think we're more typically observing regeneration or reinnervation around 6 months. So your therapy treatment interventions to target strengthening through the age-appropriate skills just resume once they're out of their swath. In instances where Botox and casting is used to optimize shoulder range in the setting where the infant's significant internal rotation, contracture, and external weakness is placing them at greater risk for glenohumeral joint deformity, when the cast is taken, usually at 4 to 6 weeks, there's an emphasis again on strengthening those antagonist muscles to improve external rotation while you continue to optimize passive shoulder external rotation. Next slide. So during the time when we're awaiting the nerve recovery and muscle reinnervation, these are just some common reasons why we might consider splinting in the infant. Making sure we're optimizing the functional position, preventing contractures, restoring the muscle length, providing stability for the joint if we need to, so that they can continue to work through normal transitional movement patterns. And as the children get older, a lot of splinting is reconsidered for many of the same reason if recovery does not occur. Next slide. So in infancy, when there is a muscle imbalance, Susan sort of alluded to it already, we do utilize that external rotation splint, the super splint as we call it, to preserve the glenohumeral joint deformity and prevent contractures. Again, this is usually used during nap time and when sleeping overnight. But we also do know that as infants go, it's often very difficult to maintain only partial splints. So as you can see, we do use long arm splints just to maintain the splint on the child so they don't wiggle out. So I have found the use of the adduction strap, which is the black neoprene strap, which I actually secure just on the posterior of the arm to the back. This has been really helpful when trying to isolate bicep firing by eliminating the child's tendency to use abduction to get their hand to their mouth. So there are some theories that it also isolates external rotation, but I have to say, based on my own clinical observations, when children have a lot of what we call baby fat or looser skin, it's really actually kind of hard to control for external rotation strengthening. The last splint that you see, the thumb abduction splints on the bottom left, we oftentimes use these until thumb extension is recovered. So that way we are encouraging as normal a grasp pattern and a release pattern as possible. So that way we don't see children ignore the unaffected hand, or the affected hand, I should say, while they're regaining their strength. Next slide. So there's some benefit from using neoprene. We call these dynamic orthotics because you can see this patient is not able to bang toys at midline without manual assistance due to weakness in elbow flexion and supination. So it makes it very hard to achieve midline play. Therefore, the neoprene supination strap can also be helpful for facilitating supination, which helps build more normal movement patterns in this age range while recovering. Next slide. So in these pictures, you can see I'm working on improving the child's ability to move through those transitional movement patterns. And by utilizing that supination strap, it also provides just enough rotation and wrist extension for this child that it allows her to better position her right forearm during midline play, but also during weight bearing. The bottom two photos show the use of the adduction strap. And this is really intended to be more isolation of the biceps while she's sitting, but also if you have her in upright sitting, it just eliminates the child's ability to abduct their shoulder to compensate for a lack of bicep. Okay, next slide. So there's dynamic supination splints, but there are also dynamic pronation splinting. So if there's a lack of pronation and there's a concern that the child may develop a supination contracture, you could utilize the supination strap, but change it to pull that child into pronation. And in instances where there's greater concern, you can see the picture on the right. There's actually a wrist splint with an upper arm cuff with a dynamic traction to really help pull that child into pronation. And this will really allow for them to also engage in age-appropriate activities while we're maintaining and preventing contractures. Next slide. So we're going to progress into the toddler to preschool range. Next slide. And as we move into the toddler to preschool age, we continue to focus on the body structure and function, but we have an increasing emphasis on activity and participation. Next slide. So in the toddler to preschool age range, we continue to assess their functional strength. But this is also important for us to keep thinking about how functional strength may be impeding developmentally appropriate participation in activities. And while we're thinking about that, we just want to make sure that we're maintaining the muscle length for all of those muscle groups that maybe are not reinnervating. So in this group, we continue to use the AMS as a tool for looking at muscle function, but then we also could begin to use the Malay classification, which has been shown, which will be shown in the upcoming slides. The AMS can be difficult for this age range, knowing that children will be children and they may not cooperate. So we continue to function, we continue to have functional range of motion and strength assessments as we did during play, but also during just clinical observation. Next slide. So it's important to assess how the child integrates their affected arm and how they use it functionally. in these images, you can appreciate how this child is using his affected right upper extremity in an assistive way with what we call a brachiothoracic grasp pattern to stabilize the object while utilizing his unaffected side. So in this image, you can also see he is using his affected arm to assist with functional, oh, actually, maybe click again so we can see the picture. Great, thank you. You can see how he's actually using his affected side for functional stabilization of the toy. So even though it's not with the preferred extended wrist and open palm position on the toy, these are things that we really should be teaching children how to use their affected side in an assistive way if there is a significant motor impairment. We just want to make sure that we don't discredit the child's natural ability to adapt to the environment in order to gain independence in play and activities of daily living. Next slide. So as we stated earlier, in addition to the AMS, the Malay classification is introduced into examinations about 2 to 4 years of age. Just like I said, it just really depends on the child's ability to cooperate. This tool has been shown to have really good validity and inter-rater reliability for the population. It involves a child following commands. We oftentimes will show them the positions and they imitate it for global abduction, global external rotation, hand to neck, hand to spine, and hand to mouth movements. So the child will eventually, after all of the motions are done, they receive a grade based upon the movements that we see clinically. Typically, this, I think more than not, we can underestimate a child's ability at 2 years of age just to imitate the positions. And oftentimes, if we can't get them to imitate those positions, we typically will put toys out to the side or behind their neck or up to their mouth, or, we can use toys to kind of simulate those motions to get a better handle on exactly how their muscle function is. Next slide. So on this slide, you can see this child is moving through all of the positions for the modified Malay. Her active motion is quite good, as you can see, but I wanted to highlight that the Pudi sign is in the picture with the arrow. This kind of tells us a good story about just how much compensatory scapular motion is needed for her to actually achieve those positions. And so that's something to keep in mind, that just because kids can get to that place where you want them to move, it's not always because of muscle strength. It could be a lot because of compensatory movements. And we do encourage, we want their scapula to glide, because this oftentimes is how they are able to complete functional movements during activities. Next slide. So in the toddler to preschool age, these are, again, examples of what may be impacted. So as we move into preschool, these are really important activities that a child will need to be able to participate in. And so we take a different perspective and we start to transition into more independence with these activities. So next slide. It is critical in this day and age that children learn to perform dressing skills so that they can independently complete toileting, which can be a requirement, at least in the United States, for some preschool programs. If midline function is not possible, it is important that we as therapists educate families that they should try to dress children in clothing that has more elastic qualities. This may include an elastic waist. We basically just want to encourage them to be as independent as possible. I have successfully used buttons that are secured with elastic rather than a hard thread. So that allows the child to wear a button-up pants if that's the only clothing that they have available. But what it does is it continues to allow them to be as independent as possible. As the pants are pulled up over the hips, the elastic band allows the the waistband to expand, but then when they're actually up to the waist, then it holds the pants in place. So next slide, we're going to start to look at participation. Participation, we encourage children in this age group to really pursue activities that they might enjoy. It's up to us to educate parents that participation in activities are extremely helpful, not only to work on strengthening and coordination, but this age group, you may see kids have decreased participation in therapy, and they also may not have any interest in really following anything that you want to do. So I think that, and that would be like in therapy. So thinking holistically as occupational therapists, we know that participation in community and social activities is equally as important for the personal factors, the well-being, and the connectedness in the community. Next slide. So on the next slide, you can just see we want to incorporate as many different activities in occupational therapy or physical therapy to really continue to work on strength, but also confidence and competence, right? For the physical, the social, and the mental well-being. So using age-appropriate activities that the patient and the family has identified as meaningful to them is really where we should be going to really get that patient and parent buy-in. By working on these patient priorities, these activity goals, we will build greater likelihood that these skills will transfer to the schoolyard, the community, directly for participation. So as you can see here, catching and throwing, making sure they gain the skills and the competence, making sure if they can, they were working on tumbling, using basketball. This little boy was really the best basketball player I think I've ever seen for his age. But I think that gave him the confidence to then go ahead, and his parents were able to put him in community activities. So the next few slides, I'm just going to review quickly. These are just age-appropriate activities for that preschool age range. Playing on, easels, hanging from monkey bars, hanging on, tree limbs, whatever, anything that really encourages bilateral participation is really important. The next slide too, these are other therapeutic interventions to continue to work on strengthening. Next slide, there you go. That way we're building strength, but we're also having them participate in activities that would be totally normal for their age range. So the next slide, we just quickly review the post-surgical therapy interventions for that preschool toddler who maybe did not have recovery, or their glenohumeral joint was at risk for deformity. So like Susan had mentioned, this is typically a common age range for patients or children to get external rotation tendon transfers. So the therapy following the cast removal, which you see, is usually, it commences at 4 weeks when that cast, or it could be 4 to 6 weeks, I should say, when that cast is removed. And we return to post-op strengthening, neuromuscular retraining to encourage strengthening of the shoulder with the specific attention to external rotation. There are some activity restrictions initially, which is really like overstretching for internal rotation, because we don't want to disrupt or overstretch the tendon transfer. However, patients and parents typically will see almost immediate results following the spica cast removal in the ability to reach and perform external rotation movements. So I'll try to speed it up just a little bit. In the toddler preschool age range, we are looking at the environmental and the personal factors. And as you can see here, I just highlighted the parental overprotection because I think there are many parents that are just requiring a lot of assurance that engaging in age-appropriate activities are okay and that they're safe. And this may also be a means for facilitating, the parents' understanding of how to engage them with peers or community, so that way we can really work on their social development. So personal factors, as we continue, you can see that there is obviously a continued consideration just about the extent of the injury and how this may impact participation. We may begin to help parents find alternative activities that are not necessarily physical and require hand-eye coordination and above head motion, but I do think that there's it's an important part of our engagement with families to make sure that they can understand just how there are other things that children can also be doing. Next. We're going to move into the school-aged. And again, we're going to continue in the next slide. We're just going to continue to evaluate using the same measures we talked about. We do this with the understanding that now in this age range, complexity of tasks, participation in activities, and independence in ADLs just gets more and more complex, and this can be challenging to overcome if we don't have buy-in from the patient and their family. So next slide, one thing that we do, this research paper really did find that there really was not a difference in children's participation in a safe manner in activities. So despite the differences in their upper extremity function and overall functional scores, children with brachial plexus birth injuries have been able to safely participate in a broad variety of sports at levels similar to published pediatric norms. So we in our clinic definitely encourage families to engage children in age-appropriate activities similar to their peers. And as they grow older, they will find their way to activities where they are the most successful. Next slide. So weight-bearing splints can be very important. As you can see in the top row, this young boy has, it takes him several steps to assume an open palm position, where in the bottom row, as Susan will show you, it only takes him 2 steps. So this support is used during therapy or home program exercises rather than full-time. You know that in many cases, children and families feel an extension splint, or he in this picture has a bivalve cast that he uses, has been really helpful to be used when to prevent elbow flexion contractures. So he wears that actually at nighttime as well. In the next slide, you will see that we also can use the elbow extension splint effectively to decrease the firing of biceps. So as you can see here, in order to move his shoulder, he really does fire his biceps. So by eliminating the biceps with that elbow extension splint, we can really work on isolating the deltoid for strengthening. Sometimes we do see this elbow extension splint effectively utilized to kind of determine whether a child actually will regain deltoid function by isolating the deltoid. Okay. So in the next slide, this is a series of pictures that I just wanted to demonstrate just how I kind of clinically go through whether a child may or may not be appropriate for tendon transfers. So this patient, as you can see, has a significant weakness through her radial nerve distribution of her right hand. She also has long-standing tightness in her wrists and fingers. So our goal in therapy was to achieve as much passive range of motion as possible. And I also utilized a dorsal wrist splint, functional manipulation skills, as she had never had the chance to do so with her flexed wrist position. So after several weeks of nighttime splinting and therapy to improve her right hand and right wrist function in the new position, it was determined that she would benefit from a tendon transfer to improve her extensor carpi radialis, her wrist extension function. However, there was actually a lot more for me to consider as part of her plan of care. And I will have more to come on this in the next 2 slides. So in my patient's case, it became clear to me that she and her mother, despite years of coming to therapy on and off, did not really fully have an understanding of her diagnosis. So I spent quite a bit of time addressing these topics to ensure the patient and the family actually really understood the condition, what surgical recommendations were being presented to them, as well as post-operative therapy needs. Honestly, it took the patient and her mother a full year to make the decision to move forward with a surgery, which did optimize their buy-in post-surgically. So again, it's our role that we fully understand what the patient and family's perspective is and what their understanding of the condition is. So that way we can best guide our educational approach. And that way we can really empower them to address what they need. So following the surgery, we continued with strengthening, moving from a more fully supported therapy intervention, as you can see, using the Coban to assist her with holding a Wii control. I was using this in a gravity eliminated plane, given that this was a new tendon transfer. And then eventually over time, as she got stronger, I transitioned to kinesio tape, which was really used to provide that feedback about her wrist position. As you can see, surgery actually really did improve her ability to reach longer distances. So she was reaching her socks and she was tying her shoes. And she was really able to position her wrist for bilateral midline tests in a much more functional position. She is now able to reach the back of her head to manage her own hair. She's pleased that she can hold a cup and a bowl so she can scoop ice cream on her own with her left hand. She's also most proud that she's now able to hold a jump rope. And she also feels like her dance moves are much more pretty now that she has an extended wrist. Next, so we are going to move into adolescence. The next slide again is we're continuing with all the clinical and the manual assessments as we did with all the other age ranges. But we do use, the next slide is that we're going to keep using the Malay. And I just wanted to put this slide here for comparison. Here you can see there's a significant difference in the 2 patients' range of motion and upper extremity function. However, when asked about the limitations that each of them had, the patient in the top row said she didn't have any concerns and that she didn't need any therapy. Whereas the child in the lower row reported moderate limitations. Again, it's up to us to respect whatever patient's perception of their function is, and therefore the child in the lower row was the one who we completed an evaluation to see if we could help her develop any strategies and determine if surgical interventions would be appropriate. So the next slide is just emphasizing participation, participation, participation. The next slide is that as adolescents begin to transition, we have to really consider that, and it starts 12, 13 years of age. We really want to start making sure that they're moving and able to transition to independent living situations. So the focus of our population is to make sure that they can do more activities that they would need to do in adulthood. So this is just a very, very brief list of things that we might be considering. So next slide. Just getting into a functional video evaluation, Susan and I actually oftentimes do conduct these evaluation functional evals together because we see things from such different angles, and that's really the importance of being open and participating on an interdisciplinary team or interprofessional team. As you can see here, her Malay looked wonderful. She had such great motion. But what I noticed as we moved into the actual video evaluation is that she was achieving all of that with significant compensatory movements. Her passive external rotation and adduction with her scapula stabilized was only to that neutral position. So it was clear that she was getting pain in her upper traps and really fatiguing with any kind of activities, as you can see, because she was using mostly shoulder abduction in all of these planes. When I asked her to show me how she cuts her food, she and her father actually laughed. And through the interpreter, her father stated, "I still do it for her, even though she's 15, because it's too hard for her." So that was really eye-opening for both the patient and her family. Her father said that they absolutely loved including her in basic cooking tasks, noting that her primary job was just peeling potatoes. So I had her simulate this with a peeler and a softball, as you can see in that lower picture. I showed her how to place the potato on the edge of the sink, peel towards the sink so she could be protected and not have to overwork her shoulder. And so it was interesting because that provided her parents with a good understanding of how, even though she has pain, there were ways to modify things that way she could do them independently. So in the next slide, really, I just want to say that in the adolescent age range, environmental and personal factors just frequently overlap. In the next slide, I think what we see and hear is in adolescence, body image and concerns around bullying continue. Pardon me. And we're showing that, children with brachial plexus, research is showing that children with brachial plexus birth injuries are at far greater risk of being obese through their lifespan than the general public. Studies have shown that anxiety and depression in the adolescent patient with brachial plexus injuries is more closely associated with their obesity rather than their functional limitations. We know that socioeconomic status has been found to be one of the strongest contributors to obesity, anxiety, and depression, and overall global function in this population. So therefore, it's really important as a team member to really make sure that we're getting the child to the appropriate providers to address their nutrition. If there are anxiety and mental health issues, to make sure that we can help provide them with the mental health support that they need. And I think, in this picture, you can really see that adolescents really begin to be most conscious and most concerned about the cosmetic length of the limb, position of the limb, how their shoulder looks, especially in females. And so, as you can see here, this was just an example of how adolescents will try to hide their affected limb in their shirt sleeves or in a convenient pocket. So these are things that I think we as therapists can really kind of holistically take a look at, be aware of, and so hopefully support them as best we can. So we're on our last slide. I just wanted to highlight that the patient-reported outcome measures and health quality have been used with this population, though researchers understand that many of those they haven't been validated for this population. So research is finding, qualitative research is actually finding that a lot of those quality of life measures are not really sensitive enough to capture brachial plexus specific issues, the extent of the lesions, and if the individual has unilateral or bilateral involvement. So I'm really happy that research is moving in a qualitative motion where they're really able to kind of tackle these issues and come up with, measures that really have stronger psychometric qualities specific to the population. So I think that in the future, we will have a lot more information to come on this, but I do think just being aware of the types of measures you use with this population is extremely important. So that was a whole lot of information. The next slide is we just really want to thank you again for inviting us. Hopefully, we've provided you with a wide enough range of information that it'll be a good springboard for your own practice.
Thank you so much. This was wonderful, very informative. Does anyone have any questions?
Yeah, I do.
Go ahead, Gerald.
Okay. Thank you, Susan and Margaret, for your comprehensive presentation. I just wanted to find out at what point do you start maybe using or start your therapy or using orthotics? Because I don't know, there has to be a time maybe to give the nerve to heal. So I don't know, some say maybe they start at 6 weeks. Do you start immediately? Let's say you get an infant who's just been maybe diagnosed. Do you start immediately or do you wait for some period of time? And another question is, when do you say the intervention, maybe the recovery has probably failed and you probably suggest surgery? I've seen you presented about some children. There was infant who, I don't know if it was a toddler, I think, who got a tendon replacement, and then there was an older one. At what point can you maybe recommend, or can surgery be recommended?
Thank you. I guess I'll try to start off with that, but we're going to tag team. So from an occupational therapy perspective, and Susan will jump in, there are concerns about, starting all that stretching immediately following birth. There's some resources that say, oh no, it should be pinned to the body and that they shouldn't move. Honestly, our team does not recommend pinning the child's, a swath to their body, because it limits their ability to actually move, which is essential for us to be able to determine if they're getting those muscle functions back. I would say that the one occasion that we will have children sometimes for comfort be swathed to their body is only when there's a severe humeral fracture. But again, we don't do that really unless there is obvious pain with the child's movement. The callus of the humerus fracture can actually show, 2-3 weeks. The lucky part about babies is that they heal a lot more quickly than the average adult. Susan, I'm wondering if you want to jump in.
I'd love to. Some of that was broken up, so I don't know if someone could help me with the questions a little bit, just so I can help jump in.
Well, Gerald, you can type it in the chat box. If you didn't have your question fully answered, you can either email me and we'll get to it afterwards, or you can type it in the chat box.
Okay, no.
Because you were breaking up a little bit. I got the first question good, but the second one you broke up a bit. Does anyone else have any other questions while Gerald's typing?
Yes. I would like to thank you for the wonderful presentation. And my question is, what is the role of developmental reflexes in the treatment of brachial plexus injury? Thank you.
Susan, do you want to go with that one, or do you want?
Maybe we can combine it. I can start. I think if we're encouraging, just to piggyback off of some of those things that Margaret outlined in terms of importance of weight bearing and importance of awareness of that extremity, and knowing that the muscle function might not be normal at that side, we would anticipate that protective reflexes might not be 100% or present. But it is something that we would try and incorporate into our treatment plan of care. specifically if we're thinking of kids, we want them to be safe when they fall. And in cases where there might not be good muscle return, sometimes our treatment intervention is geared towards teaching safe falls. But we do tend to want to try and encourage those postural and developmental reflexes as best as we can. Margaret, I don't know if you want to elaborate a little further on that.
Yeah, so I think too, as Susan was saying, we're thinking about like the ATNR and the Moro and all those things. As part of your initial evaluation, we're going to want to do all those things. And if it's only present on one side, then we know that it's a true brachial plexus probably injury. Whereas opposed to if it's bilateral, then we have to start thinking about those secondary comorbidities, or maybe it's something other than, it could be a comorbidity with the brachial plexus, but it also could be a neurological issue as a result of, the traumatic birth. So I know that our physicians always talk about the brain, like these injuries are can really be traumatic, and the most important thing is that the person delivering the baby thinks about the baby's brain so that they don't have a stroke and they don't have any anoxia or ischemia. So I think that's why it's so important to really take a good look at, like you said, the reflexes, and make sure that you're thinking globally beyond the brachial plexus injury. I don't know if that helped.
Yes, thank you very much. Also, if you don't mind, Kate, ma'am.
Yeah, go ahead.
Okay. I also have a personal experience. My son had a brachial plexus injury. So I was present during the childbirth. Right from when the doctor gave me the baby, I noticed the inversion of the hands. So I'd already suspected. So, and at the point, my prayer, so to speak, was I was praying it was a fracture, because I was scared of a nerve injury. I knew, okay, probably if it was a fracture, after a few weeks it was gonna heal up, and I was getting scared of the worst, like having a maybe Erb's palsy. So after X-ray was done, and I realized it wasn't a fracture, and it was more a nerve injury. It was a brachial plexus injury. It was Erb's palsy. I knew it was time for me to work. A bit more of an attachment, because he was my son, and I was scared. So I had to invite one of my colleagues, who is a therapist, to come in. And also because I needed more of explanation to my wife. She was scared, and it was so, but the thing, it was mild. And after resting the nerves for few weeks, we put him on an aeroplane splint, just to rest the nerve. Then we started therapy immediately, and there was so much recovery, and his by April he's going to be 2 years old, and he's totally healed up. There's no sign of injury. If not because it's going to be making a hell of noise, I would have shown him. He's in the other room, how fast he has recovered. So when I heard the topic was being taught, it was more emotional for me. I wanted to hear from a senior's perspective, how the treatment is, and it's a lovely presentation. I really want to say thank you for that. Thank you.
Yeah, you're welcome.
Thank you for sharing, Emmanuel. We do, Gerald typed in his question, and this will be the last question just due to time. I don't want to keep our presenters any later. And then if you still have questions, you can email me and I will forward them on. But Gerald's question was, I wanted to know at what stage you would consider there is a failure of recovery where surgery is recommended.
Margaret, I can try and tackle that one.
Sure.
Certainly, that's actually a question that studies and research are really trying to work hard towards better identifying. So certainly in those cases where those kids have those severe signs of nerve injury or avulsion injuries, signs where there's preganglionic injuries, those are the ones that are pretty clear cut that surgery is needed. And those, I'd say at our institution, if there's those severe injuries that we can see clinically, they usually are trying to aim to do those by 3 months of age from a surgical perspective, because they want to give enough time for that nerve that they're reconstructing, enough time for it to reinnervate towards the muscle that they're intending it to innervate. So their goal is to really try and give that function. And then that window that gets a little bit more confusing is those babies that between 6 to 9 months aren't demonstrating very good recovery. And that's where they really utilize clinical exam. Anti-gravity biceps function is really utilized as part of a standard if the baby lacks anti-gravity biceps function. Usually by 6 months of age, that's usually an indicator that they need some help from a nerve surgery perspective. But I will say, just being part of some discussion groups and working with our really awesome physicians that we have available to us, that really is something that they're really trying to better identify in terms of within that window, when is the best time. But if nerve surgery is going to occur, they do want to try and do it before that baby gets too old. So typically here, they will not do nerve transfers or nerve reconstructions beyond 1 year of age, because it really doesn't offer much opportunity for that nerve to recover to that muscle from a timing perspective. That muscle has already undergone, after 12 months of age, or it starts to go through that process where there's changes to the integrity of the muscle. I don't know if that 100% answered the question, but it is actually a really good question, because physicians really are trying to look really hard into trying to better define that when the best timing is for nerve surgeries.
Well, thank you so much. This was so wonderful.
I also just